My name is Lisa Wolf. I am the Manager of Community Engagement with the Center for Humanistic Change. So good morning to all of you and good morning to everybody on Zoom and on the hubs. Just to tell you just a couple things of how this is going to work. The next 2 hours, we have 2 speakers per, so I'm going to introduce both of them at the beginning. And we're going to try to leave about 5 minutes for Q&A for both at the end. So we'll end 40, 45 minutes after the hour. So we will take questions for them as well. When we do get a break in the next time, I want to encourage you to visit our vendor tables. There's lots of good information out there. Molly from Lehigh County brought a whole bunch of Narcan. So you are free to pick up a free Narcan kit, which my personal opinion is everybody should be carrying Narcan because it reverses opioid overdoses. And just a reminder, at the end, there is going to be a survey. It's going to be a QR code that will show up on the screen that you can use your phones to capture. If you have trouble, we can take down your email on the way out, but most people can get that done with their phone because we need to collect that data. We're responsible for that, and it really helps us make our programs better every year. So I am here to introduce the next 2 speakers. So first we have Amy Allinson Dundon, and she is the Network Director of Clinical Therapy Services for Psychiatry at St. Luke's University Health Network. With over 25 years of counseling and leadership experience, she oversees clinical operations and supervises clinicians in outpatient, partial hospital, integrated, and school-based and ACT psychotherapy programs. She is a licensed professional counselor in both Pennsylvania and New Jersey, a certified advanced alcohol and drug counselor, certified co-occurring disorder professional diplomat, certified forensic addiction specialist, and certified clinical trauma professional. Woo. Amy is the psychotherapy supervisor for 12 psychiatric residents at St. Luke's University Health Network and helps to lead the area's first integrated psychiatric and toxicology medication assisted therapy office. She is experienced with Joint Commission and state regulations for behavioral health. She co-leads the Health Network's internal crisis response team and maintains a clinical psychotherapy caseload. Today, Amy will be sharing her knowledge about the connections between substance use disorder and mental health, particularly regarding opioids. Following Amy, we have Heather Banna-Dowling. She is Director of River Lotus Healing. She is a Yusu, did I say it right? Okay, Reiki master, teacher, integrated energy therapist, advanced crystal healer, sound healer, and that's just to name a few of her unique skills. She leads yoga classes, both public and private, in trauma sensitivity, gentle, restorative, and yoga for sobriety, and facilitates spiritual workshops and retreats. She has also shared her skills in recovery centers and prisons. Heather has a private practice in Newtown and Jim Thorpe, and is also a guest practitioner in Yardley, New Hope, Richboro, and Doylestown. Today, Heather will share her knowledge and experience with alternative therapies that are acknowledged by many as integral to recovery and healing. She may even ask us to participate in a mindfulness exercise, and I hope that you will join in. So without further ado, Amy Allinson Dundon.
Good morning. I'm the clinical part of your day, which I know, but someone's got to do it, right? I'm also, I guess, Tony, boomer, so I have the glasses to see far and the glasses to see near. So I'm just outing myself right away with that. Again, boomer, got it. Okay. So thank you for having me here today. It's so very important that we all come together in spaces like this to promote wellness and recovery. We're going to zoom through today what could easily be a full day seminar, a full day lecture. I'm going to give you the 50,000-foot view of opiate dependence, treatment, and mental illness from a clinical point of view today. Arrow at the top. So mental health versus substance use disorder. I want to talk about the two of them together and then separately. So 1 in every 8 people in the world live with a mental health disorder. Mental health disorders involve significant disturbance in thinking, emotional regulation, or behavior. Now, we look at substance use disorder. Substance use disorder is widely defined as a medical condition, right? That's defined by the inability to control the use of a particular substance despite harmful consequences. Substance use disorders occur when individuals compulsively misuse drugs or alcohol and continue abusing the substance despite knowing the negative impact. They can range from severe, and we've heard all that, we know all that. So I want to say a few things about the system. So we're in the middle of a drug overdose crisis. In 2021, more than 107,000 people overdosed. Now, that's a 15% increase over prior year, and we can continue to argue, right, about the scope of addiction and the definition of addiction for years because of public assumptions. We see a lot of policies on the local and the state and the federal level that are piecemealed, right? We see a lot of policies that miss the mark because people don't understand the complexity of the disease. If a problem is feared and misunderstood, it is difficult to develop policies and procedures. We know that. The stigma of 50 years ago still impacts this now. We have separate carve-outs in insurance for mental health and physical health. Why? Right? Moving social views and political policy is nightmarishly difficult. I just came back from the Behavioral Health and Wellbeing Congress in Alexandria, Virginia, where all we did was talk about policy and how to move it. We also know that this is not a disease in which people who suffer from it come forward willingly, right? So it's not necessarily finding people to willingly help with statistics and studies and say, here I am, here's what I do, here's what I've done. It's really difficult to get the proper numbers. So that then also makes policy difficult. So this is an unequivocal barrier. Where's the threshold when it comes to national policy? And you're going to hear me talk about that a little bit because I think we have a responsibility, everybody in this room, to think about policy and lawmakers and what we can do to help move that mark. So in a national survey last year, this is the national survey on drug use and health. Here's what we found. 4 million, and this is kiddos 12 years of age, all the way up through old age or geriatric age, right? 4 million people had a substance use disorder. And this is just in the past 12 months, okay? You know, we know that 5 million had an alcohol use disorder. 6 million had a marijuana use disorder. 1 million had a cocaine use disorder. 438,000 had a heroin use disorder. 1 million had a methamphetamine use disorder. 558,000 had a prescription stimulant use disorder. 681,000 had a prescription tranquilizer or sedative use disorder. 4 million had a prescription pain reliever disorder, and 6 million had an opioid use disorder. Those are the numbers in a 12-month period that are reported. So knowing those statistics and then coming to a room like this to say, hey, it's your job to fix this. That's daunting on any level. And I think it's important to really see the numbers so that collectively as a team, we can say, okay, how do we start to tackle 1/10 of this, right, in our area? Because anything that we can do is certainly going to make a difference. So in this study from 2019, this is prevalence by mental and substance use disorder in the United States in 2019. We see the share of the total United States population with a given mental health or substance use disorder. Here, the global burden of disease study shows us when we look at drug use disorders and alcohol use disorders combined, we know that these diseases surpass anxiety disorder prevalence. So the anxiety disorder on the top, if you take the depression and the if you take the drug use disorders and the alcohol use disorders, far surpasses that. And this was in 2019. So, opiates. A natural synthetic means people are making them in labs, right? And you know, there are chemicals that interact with opioid receptors on the nerve cells in the body and brain, and they reduce the feeling of pain. A class of drugs that include prescription pain relievers, synthetic opioids, and heroin. Prescription opioids are meant to be used to treat acute pain when you're recovering from injury or after surgery, chronic pain, active phase cancer treatment, palliative care, and end-of-life care. Many people rely on prescription opioids to help manage their conditions under the care of a physician. And opioids reduce the perception of pain, but can also cause drowsiness, mental confusion, euphoria, nausea, constipation. At high doses, they can decrease respiration. Some of these meds are OxyContin, hydrocodone, codeine, morphine, and others. Some of your synthetic opioids include fentanyl, methadone, pethidine, tramadol, and carfentanil. And last night, I happened to turn on the news and I saw now that fentanyl is in lots of pretty little colors and is now being shipped in the disguise of Lego boxes. Was on the national news last night. So you never know what it's going to look like. So generally during their lifetimes, 8 to 12% of people will develop an opioid use disorder. 8 to 12% of all people are going to develop one. And of patients medically prescribed opiates for chronic pain, 21 to 29% of them misuse them. They take them not the way their doctor wants them to be taken. So those surveyed using heroin attributed their first abused drug as a misused prescription opioid. In the United States, opioid overdoses skyrocketed about 30% in the span of July 2016 to September 2017 across 45 different states. So the data does lag, but it tells a story, right? The epidemic is widespread. Based on data from SAMHSA's National Survey on Drug Use and Health in 2017, 11.1 million people aged 12 and older had misused prescription pain relievers in the past year. Repeated use of opioids greatly increases the risk of developing an opioid use disorder. Heroin is also a huge concern. In 2017, about 886,000 people aged 12 or older reported having used heroin in the past year. During that same time period, about 652 people aged 12 or older were estimated to have a heroin use disorder. So what about here? What about home, right? 4,600 Pennsylvanians reported were reported to have died by OD death in 2016. And that's the Dorothy Ryder Pool Healthcare Trust. So that's here, okay? 2018 to 2020, 31,610 doses of Narcan reportedly administered in Pennsylvania, with many more likely not counted. In the Lehigh Valley, 6,739 individuals with opioid addiction and 130 deaths in the first 5 months of 2020. The rate of 1.5 overdose ER trips per 10,000 is what's reported. And this is, again, just what's reported. The importance of destigmatizing help for opiate misuse, abuse, and dependence really can't be understated. We talked a little bit, Lisa talked a little bit about Narcan and that we have it here. Narcan, some people refer to it as naloxone, same thing, is a prescription medicine that's used for treatment of a known or suspected opioid overdose emergency. It's an opioid antagonist medication. It binds to opioid receptors and can reverse and block the effects of other opioids, like heroin, morphine, oxy. Temporary treatment, really quick. It does not last long. So it doesn't take the place of medical attention. So if you Narcan someone, if somebody needs Narcan, you use it, you call 911, you get them medical attention, because Narcan doesn't last long. It's effective, but it's very, very quick acting and short-lived. So let's talk a little bit about comorbidity and what does that mean? So when two disorders or illnesses occur in the same person simultaneously or sequentially, they're described as comorbid or co-occurring. About half of those who experience a mental illness during their lives will also experience an SUD and vice versa. Over 60% of adolescents in community-based substance use disorder treatment programs also meet diagnostic criteria for another mental illness. So what do we see the most? Substance use disorder and mental illness. Generalized anxiety has a very high correlation with substance use disorder, as we just kind of heard from Tony. Panic disorder, post-traumatic stress disorder, depression, bipolar disorder, ADHD, psychotic illness, borderline personality disorder, and antisocial personality disorder. And one of the things that strikes me as a clinical psychotherapist with these stats is, well, that's like everybody I see. So when we talk about what's the high prevalence, what's the correlation? Well, it's really everything. There's really nothing that is not associated or correlated together when we talk about SUD and mental illness. So why, right? Why? So common risk factors, both substance use disorder and mental illness are caused by overlapping factors, right? Genetic. So 40 to 60% is genetic, and epigenetic vulnerabilities. What are those? Those are changes that affect how genetic info is read and acted on and by the cells in the body. Issues with similar areas of the brain and environmental influences, such as early exposure to stress or trauma, which we also heard from Tony. Trauma is the underlying foundation block. Mental illness can contribute to drug use and addiction, self-medication with substances, and substance use and addiction can contribute to the development of mental illness. Substance use can lead to changes in some of the same brain areas that are disrupted in other mental disorders, schizophrenia, anxiety, mood, and impulse control. So what the heck do we do about this? How do we treat this? What's effective? So what we know is that treatment needs to be multifaceted. Treatment can't be, there's no one method, there's no one therapist, there's no one program. We need to be, whatever it is, it needs to be honest and real and encompass the whole system and the whole person. We need to address physical harms, psychological underpinnings, and physical aspects of addiction, as well as the social causes and consequences of each individual person's substance use. And that's millions and millions of people. So it's a big task, but I think we're finally starting to get it as a nation, as in the field of psychiatry. We're definitely treating the whole person differently and seeing better results. I want to talk about harm reduction a little bit. It's not popular with some people, but I want to talk about it a little bit. So there's a range of programs or interventions that are aimed at reducing the detrimental effects of substance use and risky behavior. Focus on reducing the physical and social harms that affect people who use heroin and sometimes other opioids, rather than encouraging the person to quit. What are some examples of harm reduction? Well, needle exchange services, safe injection facilities, overdose prevention programs, free condom distribution services. Harm reduction does not encourage drug use and may actually increase the likelihood that people enter drug treatment. Harm reduction is a door to enter treatment. And for many people, it's the only way that has worked for them to get the help that they need. Opiate dependence. What exactly is it doing to us, right? The cravings and withdrawal symptoms associated with quitting opiate use are very strong and difficult to overcome. And it's for this reason that medication-assisted treatments are often recommended. These therapies address the changes that drugs have caused in a user's brain. The most common drugs used to treat opioid addiction and dependence are opioid agonists or partial opioid agonists, which interact with and activate the opiate receptors in the brain. They create a mildly opiate-like effect, though nothing like strong opiate drugs, and they do curb drug cravings as well as opiate withdrawal symptoms. Medication-assisted therapies are safe in that they're administered by a trained physician in measured daily doses, and they're not taken intravenously, so we don't have the risk of HIV infection and such. So the two most common medications used in opiate addiction treatment are methadone and Suboxone still. Methadone is the oldest of these kinds of treatments and has been used since the 60s. And it has to be taken in certified, specialized methadone clinics. It's generally taken orally once a day. Suboxone is a mixture of buprenorphine and naloxone. It's a newer treatment for opioid dependence. And then buprenorphine, the main component, right, was approved by the FDA in 2002, so 20 years ago, and can be prescribed by physicians due to the fact that it can be taken in physicians' offices rather than solely in specialized clinics. We've expanded treatment access, and we know that these agonist meds work for MAT. Loosening some laws and regs around accessing that MAT meds can start to happen. So, take-home dosing of methadone has great outcomes. To prescribe buprenorphine, one needs an X waiver, right? So in order for docs to get an X waiver, they have to, there's a whole lot they have to go through. They become physicians, they're able to prescribe. And my belief is that, we should have either all doctors X waivered or just eliminate the X waiver and let doctors be able to prescribe. I think it will definitely help with alternative treatment. So psychological treatments for opioid addiction, motivational interviewing and motivational enhancement therapy. MI is a collaborative, goal-oriented style of communication with particular attention to the language of change. It is designed to strengthen personal motivation for and commitment to a specific goal by eliciting and exploring the person's own reasons for change within an atmosphere of acceptance and compassion. Autonomy, both implicitly and explicitly, recognizing that the client will exercise choice, asking permission, collaboration, being non-authoritarian, partnering with the patient, being non-judgmental. There's expertise that you may have, but remembering that the person sitting with you to be treated is the expert in their life and their addiction. Exploring what's important to the client, their ideas, their needs, values. Client, if you're doing MI correctly, the client's going to be speaking more than the clinician. Compassion, actively promoting the client's welfare. So with cognitive behavioral therapy, right, CBT, the initial stages of CBT for opioid addiction focus on enhancing your motivation to stick with your recovery plan. CBT is all about, excuse me, CBT is all about that narrative in our head and what am I telling myself that's making me feel this way? And how can I rewrite that narrative? How can I change what I'm telling myself? And what we found is that the CBT that we're using in psychotherapy for mental illness is the same CBT that's going to work in the work with substance use disorder. So helping people to reframe the stuff up here that Tony was talking about that just sits there and ruminates, and it grows and it gets dark and it gets scary, and we're not talking it out with anybody, and we're not actually processing and learning how to reframe our thoughts. That's why sitting down with a therapist is so important, so that you can do that cognitive behavioral therapy work. You can do the motivational interviewing and all the things, quite frankly, that we know work, that we've had years and years to refine and get right. And the fact that insurance companies are now starting to say, okay, if it works for mental illness, then let's make it evidence-based for substance use, and let's treat this all the same way instead of the stigmatizing in the therapy office as well. So DBT is another form of therapy that we use in practice. Dialectical behavioral therapy, right? Originally developed for mental illness, and now we're finding very effective in the treatment of addiction. So dialectical behavior therapy can be helpful for people who have issues surrounding control, negative emotions, or self-destructive actions. Sounds a lot like folks that are struggling with a substance use disorder. DBT can teach alternative strategies and ways of thinking to cope with difficulties that arise. Using DBT, we're able to reduce suicidal behaviors, reduce substance use, reducing bulimic behaviors, boosting self-confidence, enhancing self-respect, managing impulsivity, encouraging recognition of personal strengths, improving communication skills, teaching new life skills, and promoting positive behavioral change. And DBT goes through this in a very structured way and goes through all of these steps, and we're finding it very powerful. So 4 dimensions of recovery, and I'll wrap up so that our next speaker can talk. Recovery is probable. And I want that to be a good takeaway today, is that recovery isn't possible, it's probable. If you're following what you need to do, right? So health, overcoming or managing one's disease or symptoms and making informed, healthy choices that support physical and emotional wellness. Home, having a stable place to live. Purpose, engaging in activities. Schools, volunteering. Community, building relationships. Having a recovery plan, so that it enables you to identify goals for achieving wellness, specifying what you can do to reach those goals, including daily activities as well as longer-term goals, tracking any changes, right, in your mental health or your SUD problem, identifying triggers or other stressful events that can make you feel worse, and then seeing your PCP, your psychiatrist, your psychotherapist regularly, as if your life depends on it. And I want to just say, there's an act, we say it takes an act of Congress, but this is an act of Congress that I think we should all know about. I don't know that everybody knows about this, but it's called the Mainstreaming Addiction Treatment Act of 2021. And I ask you all to talk to your local government officials about it. It removes the requirement that healthcare practitioners apply for a separate waiver through the DEA to prescribe MAT medications. That's HR Bill 1384. Representative Tonko in New York is the sponsor, has overwhelming bipartisan support, and we're waiting for the Senate to act on it. And what the Mainstreaming Addiction Treatment Act of 2021 will do is remove a lot of the barriers that we have in healthcare that make it hard to treat, that make it difficult to treat. And Representative Tonko has really been instrumental in putting this bill together, and we're almost there. So I ask you just to look it up and do some research about it so that you can talk with folks about that locally. I want to certainly say thank you for your attention, for the 50,000-foot overview. Thank you for the work that you do in the community and being willing to carry these messages forward.
I'm Heather. I'm a person in long-term recovery. This is really uncomfortable. I can talk to prisoners and crackheads all day long. This is like really uncomfortable for me. So I'm just going to put that out there and hope that I stop sweating. So I was asked to come up here, and I have my notes so I don't forget, and I did bullet points and everything. But I want to jump in and thank Tony and good Lord, I can't even remember the last woman's name. Thank everybody for sharing your experiences and everything, and it's very helpful. And I was sitting here thinking, you know, it's really important for me to share about the MAT programs because I have my own personal feelings and I would love to talk to any of you after that. But I also want to mention Vivitrol because I know from experience personally that Vivitrol is a fantastic program for people in recovery. So I am here to talk about different modalities for healing. And Tony had mentioned that when I got sober, a huge part of my recovery has been feeling my body, right? And you had talked about that. And the mental health problem, the mental health issue that most people, opiate addicts, come from, it all stems from trauma, right? Early in our childhood. And sometimes, you know, let me check my notes. I have this whole, there's acute single incident, there's chronic, prolonged or repeated domestic violence, and there's complex, which is varied, like in multiple over lifetimes, right? So you know, everybody that I've run into, everybody that I work with has experienced various forms of trauma in their life. And what do we do with that trauma? We store it in our bodies, right? So talk about dissociation. When I come into a situation where I feel uncomfortable, I dissociate. I try to remove that situation from my life. You know, we talk about fight, flight, fawn, and freeze, right? Those are all our reactions to a situation. I chose to use drugs and alcohol, and this is about opiates, and I have experience with that. But as an addict in recovery, I also have experience with anything that's going to get me outside of myself so that I don't have to feel, so that I don't have to be in this situation where I'm being screamed at as a little child or where I'm being raped or where I'm, you know, whatever the situation is, that I can check out of my body. And a huge part of recovery for me and why I specifically work in the industry that I do is because I need to help people reconnect with their physical bodies. And it's not just addicts in recovery. It's not just addicts. It's people in general. We are so dissociated. We have no idea what that feeling is. Like, we just go about our everyday life. And, you know, the last few years, it's especially become worse and worse. So reconnecting. I love talk therapy. I love CBT. I love DBT. I love, what is it? EDMR. You know, I also have 5 kids, and Silas is my youngest. And I have also had the experience of being the mother of addicts, and some are in recovery. And we have experienced all kinds of different recovery programs. So utilizing all of that, but the most profound and the most powerful that I found, so that we are not, a lot of times in recovery, when we go into talk therapy, we get to relive our traumas. And in order to go into that, first we need to like get that stuff out of us. We need to shake it out. And there's trauma response, there's dance therapy, there's yoga. Meditation's great, but I don't know if any of you have experienced this. I teach meditation, so I hear it all the time, but a lot of people, I can't meditate. I have no idea how to meditate. I can't get my mind quiet enough. And it's because we haven't gotten all of that stuff outside of ourselves that we can become comfortable to come back into ourselves. So I'm going to do, I don't even know what time it is. I'll talk all day, or I'll talk in 5 seconds. But I was asked to present a little bit of a grounding exercise. And that's why I took my shoes off, plus the fact that I hate wearing shoes. So I'm going to ask if you guys want to take your shoes off, you're absolutely welcome to. Yay, good for you. So I want you to all sit up nice and tall in your chairs. Rest your back on the back of your chair. Can I use this thing? Yeah. Does it work? Hello? Hello? Hi, guys. So we're all gonna sit nice and tall in our chairs. Bring your feet flat on the earth. And then lift your legs up. Close your eyes if the space is available to you. If you're not comfortable, keep your eyes open. Stare wherever you need to stare. Start to lift your feet up from the front and the back, not with your legs, just your feet. And then come to rest with all four corners of the soles of your feet on the earth. Get a little taller through the crown of your head. Deep breath in through your nose. Feel your belly rise. And just let it go through your mouth. With your next exhale, relax your shoulders and soften your jaw. Bring your palms onto your thighs, connecting. Take a deep breath in through your nose and just let it sigh out. And one more time, deep breath in. Feel your belly rise this time. Breathe as big as you can, nice big balloon. And let it go. Now, following that line of breath with your imagination, visualize a line of energy coming in through your nose, down into your throat, down into your belly, down in all the way to the tips of your toes. And follow that line of energy back out as you exhale. Nothing's forced. Begin to notice any points inside your physical body that you're feeling any tension or tightness. And you're letting go of all expectation. I invite you to let go of any judgment that you have of yourself. When you find those places where you're a little bit tense or tight, there's a little bit of ache or pain or creakiness, I want you to breathe into those places. I want you to bring all of your awareness to those places and offer those places all of your love. As you move through your body, notice what is coming up for you mentally. Maybe you're thinking this lady's crazy. Notice how you're feeling emotionally. And again, you're not judging, you're simply observing where you are right in this moment. Take a deep breath in through your nose. Feel your belly rise like a big balloon. And sigh it out. With your next exhale, bring your chin to your chest. Softly feel the back of your neck lengthen. Let your eyes blink open. Keep your gaze soft at your lap. Let everything outside of yourself still stay fuzzy so that you're focused internally. And when you are ready, lift your gaze. I should have asked you to notice how you felt before you did this practice, but next time. So checking in with your physical body, how often do you do that? Do you do that every single day? I do, personally. We're so disconnected from ourselves, and it's really, really important. I used so that I didn't have to feel. I was so uncomfortable in my skin. I'm still not very uncomfortable in my skin. My sobriety date is 11/5/11. I'm super proud of that. And I've practiced multiple modality healing most of my life. I grew up with a hippy dippy mom. We did yoga. We did all kinds of crazy transcendental meditation. But I know for a fact that this helped me recover. I help people in prisons and rehabs all the time. I've had people die. I've had people get sober and stay sober. I've had my own children go through these situations. I help people in prisons connect. And they're my favorite people by far, quite honestly. My inmates are like the most fun people to teach yoga and meditation to, because they don't take anything seriously. They're just like all about being present in the moment. So I am, I'm a big proponent of getting the stuff outside of ourselves. It's really, really important to talk about experiential therapies as well as talk therapies, as well as all of the other meditation and everything. We talk about overcoming with somatic healing. That's in conjunction. One of the, I don't, what time is it? I have 5? Yay. Okay. So, yeah, over our physical response to shock and trauma, fright, and we overwhelm our physical body, our sympathetic nervous systems, and that decides if we're in a safe or dangerous place. The big thing that I want to also share, I don't know if any of you are familiar, a lot of people in the recovery, in the yoga industry, in the medical industry. Bessel van der Kolk is an author. He has a book, he has multiple books, but the most profound book that I have had the opportunity and privilege to read was The Body Keeps the Score. And it talks about how we hold trauma in ourselves. And the only way to release that trauma is to replace that trauma with something else. We need to give ourselves a new memory, right? Because we'll continue to relive all of those horrible memories, all of those things that we don't want to experience. We'll hold them in until we shake them out and do something different. And with multiple modality, with Reiki, with yoga, with movement, dance therapy, we have the opportunity to do that. But it is a holistic approach. Recovery is not just going into rehab. Recovery is not just getting sober and going to AA meetings. Recovery is a whole holistic approach, and it's an entire mind, body, soul experience. So with that, that's all I have. Thank you.
We have time for some questions. So is anybody out here have questions? I'm going to give this to Amy. If you want Amy or Heather. Questions? Anybody? All right, we got one in the back. Right. Oh, I don't think so.
I can hear you. So there are specific, I personally have trained with multiple trauma trainings. There is a program called Yoga for Sobriety, which specializes in energy work, chakra healing inside the body, as well as working with a 12-step program associating all of the mindfulness practices, the yoga, the meditation, they all incorporate all of those things. I've trained with also Y12SR is another group. I volunteer with Sync Recovery. I lead recovery hikes and yoga. We do a lot of programs. I have bruises all over my legs from a kickball game last weekend. Thanks, Megan. And so there are multiple organizations that you can contact directly. I'm based in Carbon County, and right now I'm the only one in Carbon County. Drug courts in Lehigh, Northampton, and Bucks County are fantastic resources. I think Megan has my contact information if somebody's in the northeastern Pennsylvania.
Thank you. We have a question that came on the Zoom chat for Amy. So, working in the medical field, what are some of the changes you've seen in the last few years, and what would you like to see in the next 5 to 10 years?
Well, COVID has really changed a lot for the medical field in the last 5 years, last 3 years. Specifically, our ability to virtually connect with each other, which I think is a blessing and a curse. It is super exciting to be able to have a psychotherapy session with somebody who lives in Southern Jersey and otherwise would not get to a therapist, and I can do that from Pennsylvania. I think that I've seen a lot change by way of psychiatry in the last 5 years in terms of more psychiatrists coming in and wanting more education, better education, and working with folks to have fellowships in addiction psychiatry, addiction medicine, and the stigma among physicians themselves is starting to reduce. I've seen language improve in emergency rooms in terms of how we're referring to each other and to issues and to disease. And I've seen physicians come forward without shame, without guilt to say, I need to talk to someone. So I've definitely seen some real positive changes for the better, for sure. And I just want to add to the yoga question or to the mindfulness question that, you know, if you go to a treatment center, you should always ask them, if you're in recovery, you know, what are your alternative modalities? What do I get here when I come to you? And if they aren't offering mindfulness, yoga, those sort of, you know, physical wellness, you really need to think about, are they treating me as a whole person? Because the treatment centers that are really kind of coming into their own using evidence-based practice are really more inclusive and have that as an option.
Thank you. We got one more in the room back here.
If you could wait a second for the microphone, the people online can't hear you.
Yeah. I have a comment and a piggyback, but thank you for that guided meditation, mindfulness meditation. Joseph had asked too of resources, places, and you had given some. I just want to highlight St. Luke's Penn Foundation. We put together a resiliency series, a mind, body, spirit resiliency series, and it's staff of ours who are trained and have a real passion for different practices. And we have it's all trauma informed. And so I only brought like 20 of these index cards that have a QR code that takes you to a landing page on our website. But back at that table, if you're interested, there's cards. It's all free, and that's it.
Thanks.
I'm privileged at Penn Foundation, St. Luke's, to do the Tai Chi and rhythm music therapy in the rehab. And there's a lot of that in the communities. I've been to a couple Y12SR meetings back before COVID. I can't wait till they start again because the trauma-informed part is the most important. We're all taught as leaders, because I learned Tai Chi easy through a system of trainings, again, started just before COVID, about practicing saying affirmations and language, of teaching people actually to retrain their self-messages. So it's about recovery instead of the old messages that I heard talked about so eloquently by the first speaker. And I'm also reminded that as we change stages of life, I'm a little bit older now, and I start having those imposter messages come back in, like I can't keep up with the young people on the team. I'm not as social. And then I start to realize I had that anxiety too, and it didn't go away. It just comes back at the weirdest times. I'm also in recovery 38 years, and it's great to be here and be able to get back out in the community again. Thank you.
Thank you.